Good afternoon. My name is Jennifer Sorrell, and I'm the Executive Director of the UCI Anti-Cancer Challenge. Thank you all so much for joining us. If you'd like to ask a question during today's session, please use the Q&A feature at the bottom of the screen. Next slide. Today's session is on neuroplasticity. Next slide, please. Our moderator and first speaker for today is Dr. Daniela Bota. Dr. Bota is the Vice Dean for Clinical Research at the UCI School of Medicine and the Director of the Alpha Stem Cell Clinic in the Sue and Bill Gross Stem Cell Research Center. Dr. Bota's academic research and clinical practice focuses on the innovative treatments for brain malignancies and for cancer-related neurological impairments. She currently serves as a principal investigator for numerous studies, including novel glioblastoma stem cell targeted chemotherapy agents, cellular immunotherapy studies, and wearable devices. She consults for multiple companies involved in developing drugs, cellular therapies, and devices for human use. I'll now turn it over to the esteemed Dr. Bota.
Thank you so much for your kind introduction, Jennifer. It is my pleasure to be today with you and to have the opportunity to highlight our achievements in neuroscience and to talk about the way on which our advances in neuroscience inform the way on which we treat our patients with cancer. Neuroscience is one of the pillar programs at UCI, and in reality, one of the oldest departments in the School of Medicine. It is also one of our largest departments, with many physicians and scientists trying to treat, prevent, and cure a large number of neurological disorders, including stroke, Alzheimer's, Parkinson's disease, to name just a few. Today, we have the great honor to be joined by our Chair of Neurology, Dr. Claire Henchcliffe. I will start today by introducing the way on which neuroplasticity links with the way on which we treat patients with cancer and on which we inform our decisions. And then I will pass the baton to Dr. Henchcliffe. Next. First of all, let's start with some simple definitions. What is neuroplasticity? We define neuroplasticity as the ability of the brain to undergo structural and functional changes throughout our life, and definitely in response to the new experiences that we encounter on daily living. Our brain can change and become more nimble in many different ways. The first one is by forming new cells, neurogenesis. Even if we have new cells, many of times those being neural stem cells, they need to mature and grow and form new neuronal connections. And those connections are the synaptic connections that are able to transfer information between our neurons. Another way is to take networks that are already existing and remap them by strengthening some connections or weakening other connections in order to respond to novel environmental conditions. Next. As you could see here, the brain is always an active exercising organ. Before the experiences, areas of the brain might not be stimulated. Things might look peaceful. But once the stimuli is coming to the brain, the experience produces molecular and cellular changes, which in time and after repeated exposure becomes structural changes. This is why the motor representation of the hand in the brain for a pianist or for a violin player, it is much larger and stronger than the representation for somebody that has never played an instrument. We can measure those functional changes through advanced imaging techniques that will show us the development of new areas of knowledge and of power in our brain cortex. Next. So how this relates with cancer? The one which we relate with cancer, it's a little bit more complex. In a way, it's parallel with what's happening in our population. Cancer is becoming a common condition, and it's becoming a chronic condition where the number of survivors with cancer, it's higher and higher every year. The most recent number that we had in 2016 was about 16 million survivors, and out of those, 62% were 65 or older. By 2040, we expect, fortunately, to have about 26 million patients surviving cancer, and 73% of them will be 65% will be 60 years or older. This is also important because as people are getting older, their brain loses some of its plasticity, and other injuries such as treatment for cancer can cause further cognitive deterioration. Next. The topic of our research in the lab is the cancer-induced cognitive impairment, which is also known in popular terms as chemobrain. In general, about 17 to 75% of the patients that were treated for cancer conditions develop problems with their organization, activities, memory, or they become slow in performing their activities or daily living. When we measure their cognition with advanced testing, we are able to define deficits in memory, attention, and executive dysfunction. All of those are in different degrees, with many of the patients have mild findings, while some of the patients can have more aggressive changes in their brain function. Next. We think that most of those changes are related to the function of the hippocampus. The hippocampus is a brain structure that is related to many memory disorders, including Alzheimer's disease, as well as the effects of chemotherapy. The important part about hippocampus is that it houses many of our neurons and neural stem cells that are involved in the memory formation. As such, the hippocampal neurogenesis plays a very important role in the cancer-related cognitive dysfunction. Next. We have started this type of research quite a number of years ago, looking at patients that were receiving radiation and chemotherapy for the most common brain malignancy, the glioblastoma. The structures that you see highlighted in red are the hippocampal structures. And if we look at the patients that were diagnosed in 2007 and receiving treatment to a number of 7 years, what we can note is that the very plump structure in 2007, the hippocampus in 2007, has become much smaller and atrophied with the treatment for cancer over a duration of 7 years. Next. This finding is not a finding that we find only on one patient. When we looked at a series of patients and we averaged the values over years, we are able to show that over a period in average of 4 years, the patients treated for brain cancer, if they have survived and became cancer survivors, have lost about 40 to 50% of their hippocampal volume. Next. So if this is the case for brain cancer, what's happening with patients that are getting treatment for other cancers, like breast cancer, ovarian cancer, prostate cancer? Are the medications that they take potentially affecting their brain? In all reality, many of those medications can affect the brain because they can penetrate the blood-brain barrier and subject the same areas that we talked before, the hippocampus, to additional injuries from the treatments. So we have made a mission in our lab to find ways to prevent those symptoms at the same time while we are treating the cancer. Next. The chemotherapy agent that we have studied the most, it's called cisplatin. This is a drug that we use in many adult and pediatric cancers, including lung cancer, ovarian cancer, breast cancer, and testicular cancer. Next. What is happening with this drug is that it's able to affect the energy source of the cell, the mitochondria, and it affects those cells, especially in the hippocampal area. And we find out that if cells are subjected to this drug, they are stopping their division in the case of the neural stem cells, but also they're becoming enabled to develop their connections with other neurons. Next. We all talk about oxidative stress, and we know that mitochondria is our main source of oxidative stress. You can imagine that with the chemotherapy cisplatin, mitochondria becomes even more dysfunctional and it increases the amount of oxidative stress, which in turn can damage other cells that were previously not damaged by the chemotherapy drug we use. Next. So knowing that the process that we are looking, it's an oxidative stress process, we decided to study a number of medications that have a reputation as being antioxidants, reducing the level of free radicals. And the one that we found promising is the N-acetylcysteine. N-acetylcysteine is a dietary supplement which has the ability to go into the brain. It has studied before in other diseases. And when patients have taken it in clinical trials in combination with cisplatin, there are some promising results that N-acetylcysteine can help with the peripheral neuropathy. Furthermore, in other work, the N-acetyl addition to chemotherapy did not affect the ability of the chemotherapy to cure cancers. Next. So with support from the Anti-Cancer Challenge funds, we are able to study the N-acetylcysteine and to show that if we add it together with the cisplatin to the cultures of our neurons, N-acetylcysteine is able to reduce the cell death that was caused by the chemotherapy drug. Next. We also work in animal models, and our animal models, it's female rats carrying ovarian cancer. And usually by administering cisplatin, we are able to delay the development and the growth of tumors in those rats. But the rats that get treated with cisplatin start having problems swimming in the water maze or recognizing their favorite toys. However, when we started to administer the N-acetylcysteine together with the cisplatin, we were able to measure that the animals that were treated with both drugs, not only that had delays on the tumor growth, but also are able to preserve their memory. Next. So, of course, based on this work, we plan to take the drug into clinical trials. This is another project that was supported by the Anti-Cancer Challenge funds that are donated in the past years. And we are planning to enroll female patients with stage 3 and 4 ovarian cancer or peritoneal cancer, which have not yet received chemotherapy, but they are recommended by their oncologist to receive platinum-based treatments such as cisplatin. For those patients, we will make sure that they do not have other conditions that can affect their treatment or their memory, such as head injury or dementia or other neurological disorders. Next. We plan to administer for those patients cisplatin in combination with N-acetylcysteine, which, as I mentioned, it's an oral drug, an oral supplement, and to measure through the courses of the treatment the ability of the patients to retain their memory, and a good neurological function. We were going to do those measurements through the treatment for 6 months, and then another 6 months after the completion of chemotherapy to confirm if the results that we are seeing during the active treatment can be also maintained after the treatment is completed. Next. So in addition to what I described for you, there are other ways that the patients can start receiving treatment if they believe that they might have cognitive dysfunction after they were treated for their cancers. Interesting enough, some things are very simple and non-medication based, such as cognitive behavior therapy. This was studied in breast cancer survival, and working with a therapist led to improvements in cognitive function, quality of life, as well as on the measurements of memory and attention that we usually complete. For other patients, chemotherapy induces a level of anemia or other complications, the blood counts, and treating those conditions with apopoietin alpha has attenuated cognitive impairment and fatigue, also on the patients with breast cancer. Next. Another intervention, it's a medical intervention, Provigil, which is a drug that's used for patients that have shift work, like the pilots and the nurses. And the patients with breast cancer that have received Provigil were able to have improvement in attention and memory. The last but not the least, it's so important to have an enriched environment with many new activities and many intellectual pursuits that people enjoy. And that was demonstrated on clinical trials as environmental interventions can also improve attentional capacity. Next. In conclusion, I think that it's very important to try to separate the good effects of chemotherapy, the cancer control, from the neurotoxicity. And I always joke that the neurotoxicity is the evil twin, because we always want to be able to control the cancer, but not to create long-term side effects that impair patients' life. So I think that what we would like to remind everybody today is that neuroplasticity is important. Chemotherapy can affect neuroplasticity, but those effects can be potentially prevented. And the effective interventions that we know can stimulate neuroplasticity and can mitigate the effect of cancer treatments on the brain. And those interventions are available for our cancer survivors. Next. So it is now my pleasure to introduce my colleague, Dr. Claire Henchcliffe. And I have so many things that I would like to tell you about Dr. Henchcliffe. She has had such a wonderful career. I will just give you a few details. Dr. Henchcliffe is the chair and the Stein and Weinert Professor of Neurology. She has completed her graduate studies at University of Oxford in the United Kingdom. She has then moved into advanced postdoctoral training in genetics and neuroscience at the University of Cambridge. And then we are very lucky to note that she has joined the University of California at University of California, Berkeley, where she has continued her advanced research. Dr. Henchcliffe has then moved to University of Columbia, where she has obtained her medical degree, and then her residency and fellowship in neurology and movement disorder. After that, she has joined Weill Cornell University. There she has become a world-known leader in movement disorders, focusing on clinical trials on stem cell therapeutics. We are very fortunate to attract her in 2020 as our new chair of the Department of Neurology. Her research interest, and I know that she's going to talk to you about that today, focus on novel treatments for Parkinson's disease and on data-driven personalized healthcare approach. It is my absolute pleasure to introduce you Dr. Claire Henchcliffe.
Thanks so much, Dr. Bota. First of all, I want to say good afternoon to everyone and thanks for attending. Thank you to Dr. Bota. This is an absolute pleasure to be co-presenting with her for the first time. And I've admired her work. And although I'm a movement disorders neurologist and primarily work with people with Parkinson's, I just want to note how much overlap there is between the amazing research that Dr. Bota has been doing, and you'll see and hear in the next few minutes where there are some overlaps as we're talking about brain health. So I'm not a neuro-oncologist, but I am extremely concerned with healthy brains and healthy brain aging, and neuroplasticity is really a key part of that. So let's move to the next slide. And I want to show you three really amazing images. The brain is so complex. You already got, I mean, you already know that, but the first level of complexity, I think, is when you look at it from the outside. And on the left, there's an image from a very strange art exhibition that was set up in Bristol in the UK to enhance the public's awareness about brain function and brain health. And this is a real brain encased in plastic, but you can see from the outside how complex it's a great surface area, but it's extremely complex. When you look at the inside, we have various windows on the brain that have been developed over the last few decades with increasingly sophisticated ability to take pictures of the brain. And in the middle panel, you'll see a brain magnetic resonance imaging result, an MRI. It's what we call a sagittal image. So you're kind of looking, you can see the nose on the left-hand side. You can imagine where the eyes would be. You can see the mouth. And again, as you look around, I hope this pointer is working. As you look around the surface of the brain, that really matches up very well what you see here in terms of complexity, but you can see all of these layers within. So you've got white matter, we've got the brain stem that connects the hemispheres down to the spinal cord, and these are just packed with neurons. Now, this shows you the structure, right? But I think what's really interesting is how those nerve cells are speaking to each other. And so here's a third level of complexity, which is the connections between the different nerve cells. And you can see on this absolutely incredible image here, how the networks are set up, you know, where the white matter is tracking to connect the cell bodies. And you can imagine, you can start to imagine how the cells are talking to each other in this incredibly complex network. So let's not stop there. Let's go to the next layer of complexity with the next slide, and start to think about, as opposed to structure, how some of the changes in structure can take effect, what they mean for the brain. And Dr. Bota just has told you very much, actually, in an extremely elegant presentation about neuroplasticity. So I'm just going to take a step back and a reminder, and this is the Oxford English Dictionary version. And I have to show this picture of Oxford because it's just so pretty. But the OED version is that neuroplasticity, or neural plasticity, is the ability of the brain to either develop new neurons, new nerve cells, and or develop new synapses. And synapses are simply the connections between the nerve cells or neurons whereby they speak to each other. And that happens in response to stimulation and learning. There's also maybe a genetic component. We'll come back to that. We'll see. So it's really about environment and activities and how they act on the brain, how the brain responds, and how that can help us in health and also in sickness that I want to take a look at. We used to think that the brain was only plastic and was only able to adapt in early life. And there's a wonderful, I'm going to paraphrase one of my favorite humorists, Calvin Trillin, who basically had been reading about a presentation that had been made in the White House way back on childhood development, brain development, and childhood health. And as part of the presentation, it was said that the brain could make new connections, the cells could make new connections up until 3 years old. And then those who hadn't made the connections were just trimmed out. And he thought, oh my goodness, you know, so I should really have done more with my kids than come home at night exhausted and said, hiya kids. I should have been reading to them from Shakespeare and from the Canterbury Tales. But now we know that he felt guilty, but that was unwarranted, because we know now that this, like Dr. Bota said, neuroplasticity extends throughout our lives. It decreases as we get older, but it's actually still there. And I'm going to show you a really nice study that shows that. So one of the things that I'm interested in, I'm a neurologist. I want to keep people's brains healthy. But of course, I see people when there's been some type of injury. And in cases of Parkinson's, the injury is to a particular set of cells that are very much affected by Parkinson's, and that affects people's coordination. So following brain injury, neuroplasticity, this ability to really make new connections, can allow uninjured areas of the brain to take over some of the processes, some of the activities that were previously carried out by the injured areas. And I think, you know, we talk a lot about that as we're asking people to undergo physical therapy and occupational therapy, but there's really so much more that plays into this. So let's look at the next slide. And if you could just hit next. Oh no, it didn't work. I'm sorry, go back. I had the theme song to The Good, the Bad, and the Ugly. So I've been speaking about neuroplasticity, and so has Dr. Bota, largely in terms of its advantages for us. So in health, it's clearly advantageous. So it's absolutely critical for learning and for healthy aging. It also mitigates the bad effect of neurological disorders. So I mentioned how neuroplasticity can help our brains to adapt and overcome damage and deficits that arise because of injury of cells by stroke, for example, or Parkinson's disease or traumatic brain injury. And there are so many more examples. And just as a sort of side note, neuroplasticity in very rare cases can run amok, and there can be too much neuroplasticity and too many cells doing too many things, and that can cause neurological symptoms. But that's something that I see as a movement disorders neurologist, and it's incredibly rare. So let's go on to the next slide. And I just wanted to show you some studies that have commented on neuroplasticity and how during our lives, our activities may really change the structure of the brain. And Dr. Bota has already mentioned this, but let's look at music. This doesn't have to be rock and roll, but it could be. So with learning and motor learning, differences in brain structure can actually be measured. So this has been demonstrated in multiple studies, but the one that I'm showing you here was in performing artists, professional and non-professional musicians in the case on the left. So although these are not scans of those 4 fine young men on the bottom right, these are scans that compare differences in structure in the brain between people who are professional keyboardists versus amateur versus people who are non-musicians. And you'll see there's several areas on the left, and these are highlighted in yellow and orange. These are areas in which people who are professional keyboardists actually had a slightly larger brain area in that region. And these are actually in areas, it's the gray matter, it's the cortex, and these are areas involved in movement control, so motor control, auditory, so the hearing, and then visuospatial skills. So you could look at an experiment like this of measuring volumes of of cortex in people's brains and say, well, maybe it's the music and the learning that resulted through neuroplasticity in having differences in these volumes. But maybe it was that they started out with the differences in volume, and that's, you know, that made them good musicians and they were more likely to be professional. So let's look at the next study that I think really refutes that. And I've worked on dance for, well, I started working on dance when I was back in New York because it seemed like a really great therapy for my patients with Parkinson's. But here's a little bit of background. In animal studies of neuroplasticity, it seems that when the animals hit adulthood, it's really a combination not only of physical activity, but also sensory enrichment that leads to lasting changes in the brain. And the people who did this study on the left said, well, hey, physical activity and sensory enrichment, it sounds an awful lot like dance. And what they did was they took about 40 people who were a little bit older, early 60s, up to 80 years old, and they decided over 6 months that they were either going to train on a really challenging dance sequence, or they would do conventional fitness training. So actually, in terms of the imaging and the MRI and looking at volumes in particular areas of the brain, there were changes in everyone. So the conventional fitness training and the dancing actually seemed to result in larger volumes in particular areas of the brain. So that's great. But in the people who had been dancing, seemed like the increase was greater, and it also seemed to be in more areas. So I'm not trying to say that dance is superior to conventional fitness training, but there's definitely a difference here based on the imaging. And the other change that these people found, this research team found, is that when they looked in the bloodstream at levels of various peptides that we believe are neuroprotective, there was one peptide in particular, it's the brain-derived neurotrophic factor, BDNF, and it was elevated, but only in the people who had been doing the dance sequences. So this is over a 6-month period. So it looks like, and this is quite astonishing, I think, you can actually change things over 6 months. I just wanted to mention before we go on to the next slide, from my country, there's a famous study that was done in cabbies, the taxi drivers in London, and they have to acquire a certain amount of knowledge. It's called the knowledge. And it's basically learning routes for driving. It's about 25,000 city streets in London. It's completely ridiculous. And there was a team who was studying these people who said, well, does it make any difference to their brain structure? And they were looking specifically at the hippocampus, which is involved in memory. And they found that indeed, in the cabbies in general, it was increased. But what was really interesting was they followed people over a period of 4 years, and they scanned everyone, all of the cabbies, at the beginning of their training. And at the end of the 4 years, they had to do an exam, and they compared the scans of those who passed the exam, and they knew all their 25,000 streets, versus those who failed the exam. And actually, in the people who were successful, there were greater changes than the people who had failed. So there's definitely something going on here that means that we can, through our activities, change the structure and change the activities in our brains. And I think that's something really interesting in health and in people who suffer through any type of illness. So let's go on to the next slide. We have a huge stroke team in our department. I've put their pictures up top right, and also we have a new faculty who's joined us to look at traumatic brain injury. But after stroke, you tend to see very fast, hopefully, in the majority of our patients, improvement as the swelling goes down and as blood flow returns. And then after that, there's some continued improvement over time, and neuroplasticity has a role in that. But the problem is, as we all know, there are sometimes, well, there are often residual deficits. So people just don't get back to their baseline. So what do you do when there's been sufficient damage that your neuroplasticity has helped, but it really can't go any further? So next is a little picture just to highlight one of our early career faculty. He's absolutely incredible researcher. Dr. Ando is working on mitigating this final deficit and trying to help people who've had either traumatic brain injury or stroke by using machine brain interfaces, which I think is an absolutely ingenious way to go. And then next slide. What I've been doing in my group and other people in the movement disorders group is looking at the potential for regenerative medicine. So remember the two parts to neuroplasticity. One is you make new neurons, which the brain can't do very well, as opposed to the liver and the bone marrow, etc. And then two is the neuroplasticity. But if you don't have cells there for plasticity, you're sort of stuck. And the picture on the right is just to remind me that some organs like the liver, the bone marrow regenerate. And this is poor old Prometheus, who was punished by the gods. I think it was for stealing fire. And he had his liver pecked out daily and it regenerated daily. So that's a great story for lunchtime. But again, reminds us that some organs in the body truly regenerate beautifully. The brain can a little bit, but not very much. So the question is, could we take on the role of the regeneration and then provide cells back to the brain that then can become the substrate for changes, new connections, those neuroplastic processes? So next slide. I've been working on this through Parkinson's disease, but others have been working on this for traumatic brain injury and other types of brain injuries. And we hope that down the line, this may provide information that's going to make it helpful across the board for people with neurological problems. So we have been looking at how to transplant cells in Parkinson's disease. And what I'm showing you here is a scan with the dopamine cells, having this beautiful input and release of dopamine into these deep structures in the brain called the caudate and putamen. And you need that dopamine release to be able to move. If you don't get it, the downstream movement networks don't activate and people get slow and they get uncoordinated. And this is someone who has Parkinson's disease, and you'll see there's some dopamine getting in there. You can see it on this brain scan, but a lot is not, it's just missing. And that's what slowed down. This was one of my patients and he was slow, he was incoordinated. So we have a lot of medicines we can use for Parkinson's, but wouldn't it be great, because their activity wanes over time, wouldn't it be great if we could provide the cells that the brain cannot regenerate? And next slide. So using advanced stem cell technology, I was working with a group actually out of the Memorial Sloan Kettering Cancer Center who do amazing stem cell work in New York. And they managed to devise a method of preparing stem cells that could be grown to an unlimited number in the laboratory. They could be coaxed in the laboratory to become nerve cells producing dopamine, and then we could transplant them. So that's turning about 15 years of really hard work of a huge team into one sentence. But the bottom line is, with the help of Blue Rock Therapeutics, who funded the study, and with the enormous support of the UCI Alpha Stem Cell Clinic that is led by Dr. Bota, we now have finished enrolling for a first in human study in which patients receive transplants to each side of the brain of these cells in an attempt to restore what had been lost. So next slide. Our cells are not immunologically matched. We used a cell line that's been studied for years and years and years in the knowledge that we have a great deal of information about its safety and its activity. However, there are other groups now who are transplanting immunologically matched cells. One of them, Dr. Philippe at UC Irvine, is working again with the Alpha Stem Cell Clinic, funded by a company called Aspen, to enroll people with Parkinson's and make their own stem cells. And down the line, we hope that those will be amenable for transplantation. The panel on the left, I was involved in a study in which we performed a transplantation of a patient's own cells to one side of the brain in New York, and the second side of the brain he went to Massachusetts General with his primary research team. And it was safe, it was well tolerated. The graph shows that his quality of life improved. We can't read too much into that because it's a single patient and there was no control, but still it was a good first step. And a Japanese group led by Jun Takahashi in Kyoto are transplanting patients with donor cells that they are able to immunologically match. So next slide. So I hope this conveys some of the excitement that there is in the field for the ways in which we're going to be able to help people live longer and healthier lives. We know the human adult brain can adapt in a very sophisticated way, not just in health, but also when there's been damage, making new connections, strengthening specific networks, and even making new nerve cells. And I think whatever the type of illness, this all could be helpful, but we have to understand more about how to modulate it and how to help it along. I think one of the big things you can guess from the slides on music, the cognitive activity with the London cabbies and the dance activity is really key. And this is it's a really critical area of research now, how exercise and other brain activities strengthen and improve function of our nerve cells and can really enhance neuroplasticity. So that's huge. And then in the future, my hope is, and certain others are with me, that novel stem cell technology, computer interfaces, and surgical transplant might be able to augment and support our own brain's natural plasticity by providing back those cells that have been lost and can't be replaced by the brain itself. But then the brain can take the next step, which is to make those new connections and fire up those networks that were not working to help our function. So I'm going to stop there. And thank you very much, everyone, for your attention. And again, absolutely delighted to be part of this wonderful anti-cancer challenge. And this is an acknowledgement to the people I've been working with.
Thank you so much, Dr. Henchcliffe, for this wonderful presentation. It will be a good time right now for us to take questions. It is quite interesting that we have basically a parallel question for the two of us, which is, what other ways besides exercise can we use to enhance neuroplasticity and healthy aging?
Okay. Do you want to start with that, or shall I've got loads of things.
I would like you to start with it.
So the exercise is really the big one, but then I think Daniela, Dr. Bota, you talked a little bit about some of the mechanisms and the underpinnings of neuroplasticity, and we know that so many of the pathways in brain cells that are involved with brain health will fundamentally affect neuroplasticity. So, you know, you have brought up oxidative stress, which is something that I used to work on. So I think diet, the oxidative stress, and obviously exercise affects that as well. There's some, I think, really sound cause for optimism that other lifestyle changes like getting enough sleep is helpful. And then I think there are a lot of questions about our diet, right? You know, there's a lot of data about the Mediterranean diet and healthy aging and avoiding cognitive decline. So I think, unfortunately, we don't understand even a small percent of what's going on, but we do know that some of these things really work to help promote healthy brain aging. But I was really interested in what you were talking about with the N-acetylcysteine, because we've been talking about that in my field as well.
So yes, excellent introduction to our story about N-acetylcysteine. And we know that many of the drugs that we use as chemotherapy, as well as many of the toxins from the environment on which we live, tend to affect mitochondria and produce free radicals and cause free radical damage. And there's a series of antioxidants that are important to study N-acetylcysteine being maybe the parent compound, those novel compounds being derived and developed every day. What is important to note is that it's quite different to try to maintain healthy brain versus trying to maintain healthy brain in a patient that's treated for cancer. And we have to be very mindful that medications that we use for one indication do not hinder the treatments that we offer for other indications. One of the questions that we had was about the regular use of N-acetylcysteine and Provigil to improve cognitive function on older population without any other cancer diagnosis. And I'll say though some of the things sound interesting and they might be potential options, it's also important to realize that we need to study those questions in very well measured and organized ways in clinical trials in order to make sure that we truly know the right doses and the right combinations to help protect the brain. Dr. Henchcliffe, we have another question about the genetic factors that might affect neuroplasticity. We know that different people age or suffer of neurodegenerative disorders in different ways. Would you like to share?
Yeah, I think it's been very poorly explored in neuroplasticity, but we're all so different, and we all have our own individual genetic makeups. And I think in the field of oncology and neuro-oncology, I think you're really way ahead of the rest of us in neurology in terms of figuring out how the genetic makeup affects people's prognosis, people's response to medication, and so on. And so that's something that I'm really interested in. And as I was looking at some of those issues recently, I was focused on how we respond to medicine. And then what I hadn't really thought about before was, well, how do different people respond to rehab and physical therapy and occupational therapy? And we know that some people do incredibly well with physical therapy, and we know that other people, they do well, but it's not quite that huge change that some people get. And I started looking into it, and I think what had not been on my radar is that some of the molecules, well, one of the peptides, one of the small proteins that we've been talking about, like the brain-derived neurotrophic factor, obviously there's a gene that encodes that, otherwise we wouldn't have it. And some changes in the BDNF gene might be related to people's different, or might be related to an organism's different response to exercise, for example. So I think there's some evidence in animals. We don't know in people, but I think this is going to be something that is, you know, as we get further and further into precision medicine, I think this is going to be something that is really interesting to look at.
Absolutely. And this lines very nicely to one of other questions that we have received, which ask about if after craniotomy for a brain tumor, could the remaining parts of the brain be retrained to fill for the removed parts? And do occupational therapy, physical therapy, and speech therapy help with that, or are able to do that? And I think this is a little bit of a complex answer, because it's yes, no, and maybe. The reason for which I'm saying it is that definitely neighboring parts of the brain can take the function of parts that were removed. And with time and with training, either physical therapy or occupational therapy, patients can regain partially function. However, if we are looking at major functions like motor function, if a patient is paralyzed because a motor area was removed, the neighboring areas are neurons that have different functions. They are structurally and functionally different in their activities. And it's very hard, if not impossible, for neurons that are involved maybe in sensory function or in speech to take over motor function. And that's why it's so important, the type of research that Dr. Henchcliffe has just mentioned, where part of the functions can be replaced by robotic arms or exoskeletons or other engineering solutions that some of our faculty are developing. I'm wondering, Dr. Henchcliffe, if you want to give us a little bit of the flavor of the things that are happening in the departments that can supplement lost neurological function.
Yeah, I think this is, I think in at UC Irvine and Dr. Bota, you've been here much longer than me, so you've really seen how this all grew. But I've been really impressed arriving 2 years ago by how sophisticated the approaches are that are being taken in a number of different neurological areas. So I mentioned Dr. Doe, who's looking at machine-brain interfaces, and I noticed he sent out a number of emails recently saying, do we have people who would want to participate in a clinical trial with him, where he is trying to look at improving motor function right now in people who've had a stroke. So I think that's it's incredibly sophisticated, and I think he's really one of the preeminent researchers who's trying to do that. I mentioned what we're doing in Parkinson's, but not only are we trying to develop cell therapies for Parkinson's, there is another movement disorder which is quite rare, and it's genetic Huntington's disease. And this is not part of my own department, although we're involved and we're supporting Dr. Thompson, the lead researcher. But Leslie Thompson has been doing incredible work to develop a stem cell-based therapy that might help people with Huntington's. And Huntington's is unfortunately a progressive movement disorder where people lose their coordination. There are a lot of other problems as well, and we really don't have a way of slowing down the progression. We have some sort of treatments for the symptoms, but it's nowhere near good enough. And then I think another area where it's also progressive, and we certainly don't have a cure, and the treatments are there but limited, and that's Lou Gehrig's disease. So this is a disorder that leads to weakness, including weakness of the muscles that control breathing. So that's really, really tough on patients. But we have in Dr. Mozafar's team, Dr. Korb, Dr. Goyal are doing really amazing work to try to help develop new therapeutics. So a lot of these are cell-based. And then I think the other interesting part is what could we do through gene reprogramming? And I don't think that's really been explored so much for most of the pathways, the cellular pathways that are important in neuroplasticity. But for example, there have been teams, we have both brought up brain-derived neurotrophic factor, the BDNF, which is protective and helps with neuroplasticity. But there's a similar one, GDNF, glial-derived neurotrophic factor. There are groups who are looking at delivering this factor using gene therapy. So could that be another way of effecting some plastic changes? I think this is all, it's a very early field where it's all to discover.
Dr. Henchcliffe, thank you so much for being with us, but also for giving us such a broad and wonderful view of the things that we can do to promote neuroplasticity and to understand neuroplasticity in general. I think that Jennifer would like to join us right now and to help us conclude this wonderful event. Jennifer?
Thank you so much to Dr. Henchcliffe and Dr. Bota for this fascinating session today. And in closing, if you haven't yet already, we do invite you to join the 2022 UCI Anti-Cancer Challenge, which is an annual peer-to-peer fundraising event where participants sign up to ride, run, walk, or volunteer and raise money for cancer research. We work with corporate partners to underwrite the costs of the event, so that 100% of proceeds go directly to cancer research at UCI's Chow Family Comprehensive Cancer Center and Chalk Children's. And we've had 9,300 participants sign up since 2017, raised more than $2.6 million for research. Next slide. And we're very excited that the 6th annual Anti-Cancer Challenge is coming up in just a few weeks on Saturday, October 8th at UCI's Aldrich Park. It will be a hybrid event with opportunities to participate in person and virtually. The in-person challenge day will include a 5K, 10K run walk, 14, 35, 60, and 100-mile bike routes, live entertainment, a family-friendly festival, and awards. Next slide, please. So we hope that you'll consider starting, joining, or supporting a team. And again, all proceeds support promising pilot studies and early phase clinical trials that can help prevent, treat, and cure cancers. Next slide. And if you'd like to sign up to receive reminders and anti-cancer challenge news, please scan the QR code on the screen or visit the website listed. So again, thank you so much for being with us and have a wonderful rest of the day.